Hello, everyone in the room and those joining online. Welcome to KITE Research Rounds. It's my great pleasure to introduce our speaker, Professor Oury Monchi. I'm going to introduce our speaker briefly, and then he'll start the talk. Dr. Monchi obtained his PhD in computational neuroscience at King's College London in the UK. He then pursued postdoctoral fellowship at the Montreal Neurological Institute and the Geriatric Research Institute in Montreal in neuroimaging applied to Parkinson's disease. Until the summer of 2014, he was Associate Professor of Radiology at the University of Montreal and scientist at the Research Institute. From 2014 to 2021, he was Professor and Director of Clinical Research at the Department of Clinical Neuroscience at the University of Calgary. During that time, he held the Canada Research Chair Tier 1 in non-motor symptoms of Parkinson's disease and the Tourmaline Oil Chair in Parkinson's disease. Since 2018, he is the director of the Canadian Open Parkinson Network, a platform funded by Brain Canada and Parkinson Canada. Since November 2021, Professor Monchi is the scientific director of the Geriatric Research Institute at the University of Montreal and full professor of radiology, radio-oncology, and nuclear medicine at the University of Montreal. Professor Monchi's lab has been a pioneer in using different neuroimaging techniques to study the origins and evolution of non-motor, including cognitive and neuropsychiatric deficits in Parkinson's disease, with the ultimate goal of the early detection of dementia in the disease. Non-medication therapies such as transcranial magnetic stimulation and low-intensity focused ultrasound are also being explored. Methods used include functional and anatomical MRI, TMS, neuropsychological and neuropsychiatric evaluations, genotyping, and machine learning. In collaboration with Professor Pierre Rainville, Dr. Monchi has recently started to study the origins of chronic pain in Parkinson's disease. Please join me in welcoming Dr. Monchi. And as a reminder, at the end, if you have any questions, please come to the mic.
Thank you very much for the introduction and the invitation. I've really enjoyed seeing all the things that I've seen so far. So yes, I'm going to be talking about non-motor symptoms in Parkinson's disease. Am I too far, possibly? Work better? Oh, sorry, I was pressing the wrong button. So Parkinson's disease is diagnosed by its motor symptoms that include bradykinesia, which is a slowness to initiate movement, rigidity, tremor, and gait problems. However, we now know that it's associated with many non-motor symptoms. This is from a paper from Kalia and Lang here in Toronto. And so we know, for instance, that in nearly all patients, constipation occurs and that it can occur up to 20 years prior to the disease. There's also sleep problems such as REM behavioral disorder, which if you have it alone, idiopathic RBD means that you are most likely to develop either Parkinson's disease or Lewy body dementia in the next 10 years. So also hyposmia, problems with smell, is very common in the disease and can occur prior to the diagnosis. And we'll be focusing on three main non-motor symptoms: neuropsychiatric ones, such as depression, anxiety, but also many other neuropsychiatric symptoms. Cognitive deficits are very frequent in the disease. In the early stages, they often take about 40% would have what we considered as mild cognitive impairment. And what's impressive is that up to 80% of patients will develop dementia within 10 or 15 years after diagnosis. Another frequent non-motor symptom, which is a bit overlooked, is pain. and yet it affects very much the quality of daily life of patients. And chronic pain is much more frequent in Parkinson's disease than it is in the general population. So it's a bit of an old study. Like in the general population, the presence of mild cognitive impairment in Parkinson's disease indicates a much faster rate of developing dementia and a much higher occurrence of having it. This is one of the early studies, but there's been many since. So what do we know about the neuropathology? It is associated with the presence and the deposit of Lewy bodies, which are the cells made of alpha-synuclein misfolded aggregates. Based on their spatial temporal deposition, Brack et al. Have developed a model of their evolution in the brain. What they propose is that in the preclinical stage, in the prodromal stages, the deposition of Lewy bodies is mostly present in the brainstem and in the olfactory bulb. At the time where the motor symptoms appear and the disease is diagnosed, this evolved throughout the brainstem, but also in the subcortical regions, including the basal ganglia and the substantia nigra, and start touching the cortex in the orbitofrontal lobe and the primary visual cortex. As the disease develops and the cognitive deficits are more and more apparent, going all the way to dementia, Lewy bodies now start to spread throughout the cortex, including the parietal lobe and the temporal lobe. So one of the hallmarks of the neuropathology of Parkinson's disease is the degeneration of the dopaminergic neuron in the substantia nigra. Here we see how it looks usually and how it looks like in patients with Parkinson's disease. The substantia nigra itself projects to the striatum, which includes regions such as the putamen and the head of the caudate nucleus. And because of that degeneration, this affects the activity that are linked to what are called corticostriatal loops that links different regions of the striatum to the cortex via the thalamus and the globus pallidus. So schematically, there's a motor loop, which is the one that is mostly affected at the early stages of the disease and affects movement, but there's also a similar cognitive loop, which links the head of the caudate nucleus from the prefrontal cortex. And when I started with brain imaging a long time ago, we wanted to develop an fMRI protocol that would allow us to isolate activity in such a loop to then study it in Parkinson's disease. So to do that, we used a card sorting task, which is known in neuropsychology, the Wisconsin card sorting task, which tries to evaluate how you adapt to a changing environment, or in this case, a change in rule, an implicit change in rule. I won't go through it, but we modified a bit the task, adapted it to what's called event-related fMRI, so that you can take little temporal parts of your tasks and see what's associated with them. And what we showed was that in healthy individuals, young adults, there was a significant increased activity in the ventrolateral prefrontal cortex, the caudate nucleus, and the thalamus, so in such a cognitive cortex. So we had isolated a cognitive corticostriatal loop, including these regions, in this process, which was planning a set shift. So when you're told that you're wrong and you plan to do something else on the next trial. So many years later, about 10 years later, we studied a group of patients with Parkinson's disease who were two groups of patients with Parkinson's disease. Both groups were at the same stages of the disease. They had the same amount of motor symptoms, were taking roughly the same amount of medication, same time since they had the disease. They were matched for all these things, but the difference was that one of them had mild cognitive impairment based on a long neuropsychological evaluation, whereas the other didn't. And what we found is that using the same fMRI protocol, is that the Parkinson's patients with normal cognition had the pattern of activation you would expect with ventrolateral and caudate nucleus activation, whereas it was only the patients with mild cognitive impairment who had significantly reduced activity in those regions. This was in accordance with a similar paper that came out in Lancet Neurology about a year before, which showed using an NBAC task some similar results. We also tried to look at the dopamine transporter gene, whether it would have an effect on the patterns of activity we see in Parkinson's patients. So this is called the SLC6A3 gene, and we looked at the variant number of tandem repeats. And what we found is that the 1010 carriers had the healthy pattern of corticostriatal activation, whereas the 9 carriers had significantly reduced activity. Also, there were many more. The cognitive profile of the 9 carriers was much worse than the 10 carriers. Then we tried to look at longitudinal studies. We tried to find, we aimed to find out what are the patterns of activity during that task with fMRI that are most predictive of cognitive decline over 20 months. So we took all of our patients, we scanned them at time 1. We actually scanned them also at time 2, but in here, what I'm showing you is scans at time 1 that are most predictive of MoCA evolution over 20 months. And what we found is that the least the patients were using the mid-temporal lobe and the thalamus, the most they were likely to decline cognitively as measured by the MoCA. We also looked at anatomical correlates using MRI, so looking at some different types of gray matter measures, such as cortical thickness and subcortical volumetry. So we looked at that longitudinally in patients with and without mild cognitive impairment, as well as a control group. So once again, the presence of the MCI was the one that predicted the worst outcome. So only in the MCI group was there significant decrease, was there significant cortical thinning over time overall. Regionally, when we compare the groups, there was significantly thinning over time in the Parkinson's patients with MCI compared to the Parkinson's patients with normal cognition in the medial and anterior temporal lobe, in the SMA. And when we compared the Parkinson's patients with MCI to healthy controls, there were even more regions. Once again, the medial and the anterior temporal lobe, the SMA, but also the parietal lobe and some visual areas. But interestingly, when we compare the Parkinson's patients with normal cognition compared to the healthy controls over time, there was very little more thinning in the Parkinson's patients. So it would seem that the cognitive effects are very important with respect to at least the cortical neural degeneration. Similarly, in the subcortical regions, what we found was that the only group which had significant shrinkage was the Parkinson's patients with MCI, where the significantly more shrinkage in the amygdala and the nucleus accumbens compared to the other two groups. And this is interesting because the nucleus accumbens is part of what's called the ventral striatum. The reason this is interesting is because it is thought that the evolution of dopaminergic degradation in Parkinson's disease evolves from the dorsal striatal to the ventral striatum. And even though the two groups of patients were at the same stage of the disease, it would seem that that evolution is much faster if you have cognitive deficits than if you don't. This needs, of course, to be tested on a larger sample. So more recently, we started to use machine learning to predict cognitive decline in the disease. But these are, so the way to some of you, this may be quite basic, but just in case. So the idea is to put a whole bunch of input features, and then we use two classes of algorithm. One is a feature selection and feature ranking algorithm, and then we apply either a classifier training to say these have PDMCI or these don't. But in our case, we did not use a classifier. We used, because we had a continuous variable, we were trying to predict MoCA evolution over time. So we used, we used a machine learning regressor instead. So we started with a machine learning model to predict the brain region whose gray matter changes are the most predictive of cognitive decline using MoCA. For that, we used a data set which is called the Parkinson's Progression Marker Initiative, which is funded by Michael J. Fox in the United States. So we had 290 de novo PD patients, and we looked at MoCA evolution over 4 to 5 years. So what we did is we took their anatomical MRI or T1 MRI and had measures of cortical thickness and subcortical volumes like we did in the prior study. We put some demographic and clinical data. Our ranking algorithm was RELIEF, and we used a support vector regression to predict MoCA evolution. And what we found is that the most important features to predict MoCA evolution were years of education, baseline MoCA scores, volume of the right pallidum, volume of the right fusiform gyrus, and the volume of the right hippocampus. So once again, the mid-temporal lobe was shown as being one of the most important features for predictive cognitive decline in the disease. So we then run another model, including many more features, particularly some CSF biomarkers, which are obtained using lumbar puncture, as well as some genetic variants that are known to be involved in cognitive deficits in Parkinson's disease. We still had the MRI markers of gray matter. And interestingly, what we found is that only the CSF biomarkers were selected by the model. Neither the neuroimaging or the genetic variants were selected. So one of the possibilities is that the CSF biomarkers do contain some of this information already, because in those machine learning type of models, you take what's most useful, but you don't take anything that's redundant. They don't select anything that's redundant. Interestingly, the REM behavioral sleep disorder was a selected feature in accordance by studies by Jean-François Gagnon and Ron Posthumer that shows that RBD is in the disease is very predictive of cognitive decline and of dementia. And what's interesting is that many of the CSF biomarkers, which was p-tau, t-tau, amyloid beta, so this is the most predictive to the least predictive, but it contains, but all of these are predictive. And it's interesting that many of the CSF biomarkers selected by the model are associated with Alzheimer's disease pathology. So it seems that there's been various evidence showing that the cognitive symptoms in Parkinson's disease do share some neuropathologies with Alzheimer's disease. So we also looked at some diffusion-based imaging, which you might have heard as DTI or diffusion tensor imaging. So we had, once again, groups of Parkinson's patients with and without MCI, as well as healthy control. We took some cortical regions of interest and some subcortical ones, and we looked at the white matter tracks, linking them. These are all the measures we looked at. I'm not going to go over them. They're mostly linked to some form of white matter integrity. So these are the subcortical regions we were interested in. So you'll see the putamen, the GPI, the caudate nucleus, the ventral striatum, and the hippocampus. And I'm just, this is a 3D rendering of these regions. I'm just going to give a summary of the main result. So for connection between the primary motor cortex and the putamen, which can be considered as motor related, what we found is that both groups of Parkinson's patients with normal cognition or with MCI had significantly reduced white matter integrity compared to the healthy controls. On the other hand, when looking at projection between the dorsolateral prefrontal cortex and the caudate nucleus, which are supposed to be more cognitively related, then we found that only the group with mild cognitive impairment had significant decline in their white matter integrity. If anything, it would seem that the Parkinson's patients with normal cognition might have had a compensatory mechanism going on compared to the healthy control. But at least they did not degrade significantly. More recently, we started studying neuropsychiatric syndromes to see if they might be precursor to cognitive decline in Parkinson's disease and in general, a bit like SCI might be a precursor to MCI. So we've been focusing on a syndrome which is called mild behavioral impairment. It's a neurobehavioral syndrome to identify patients with increased risk of developing dementia. It has been proposed by Zainur Ismail and his colleagues at the University of Calgary. It's characterized by later life emergence of sustained neuropsychiatric behavioral and personality changing lasting more than 6 months. And this is important because this is how it differs mostly, for those who know, from the NPI, the neuropsychiatric inventory. It cannot be explained by the presence of late life psychiatric, often pre-existing general psychiatric illnesses such as depression and anxiety. So if you have a change in your depressive or anxiety symptoms, that could be mild behavioral impairment. But if you've been depressed most of your life and you still are at a later stage, then it wouldn't be considered as mild behavioral impairment. And it's been studied in the context of Alzheimer's disease and frontotemporal dementia, but not really in Parkinson's disease. And non-Parkinson's patients with MBI have a higher, it has been shown that they have a higher conversion rate to dementia than a comparator group consisting of late-life psychiatric disorders or than patients with no neuropsychiatric symptoms. So what we want to do is study this in the context of Parkinson's disease. So how do you diagnose this syndrome or assess it? Ismail et al. Developed what's called the MBI checklist, which only takes less 10 minutes to complete and can be filled by the companion, the caregiver or the partner. The MBI checklist evaluates 5 domains of neuropsychiatric symptoms: apathy, mood and anxiety, impulse, discontrol, agitation, social cognition, and psychosis. And prior to our research, there's been a few now, no research evaluated the association between mild behavioral impairment and cognitive deficits in Parkinson's disease. So we studied 60 idiopathic Parkinson's patients at Hernania stages 2 and 3. And based on the MBI checklist scores, we created 2 groups, a group with high MBIC scores, which we called with MBI, and a group with low MBIC scores, which we call without MBI. So what we found when we compared the 2 groups, those with MBI and those without MBI, once again, similarly to our studies with MCI, they were matched for the Z stage and so on. What we found is that the group with mild behavior impairment had significantly more deficits on every single domain of cognition we studied, which is attention, executive function, language, memory, visual, spatial, and obviously if they do, then they also had it globally, compared to the Parkinson's patients without MBI. We also looked at this in another way. We took the MBI checklist in all of our patients, and we correlated it with the Z-scores of each of the domains of cognition that we were investigating. And what we found is that, once again, there was a significant anti-correlation between the MBIC score. So the higher the MBIC score was, the higher the neuropsychiatric load was, the lower were the performance on the different different domains of cognition we were evaluating. And that also included the MoCA. Now, you could say, but that might be because the people with MBI were more likely to have MCI. So we control for that. We did another analysis where we control for that. And what we found is that even when controlling for the mild cognitive impairment presence, the MBI score had a significant anti-correlation in the memory domain and the visuospatial domain, as well as globally. This is interesting because these are the 2 domains which are thought to be the most predictive of dementia in Parkinson's disease, according to a theory that I didn't have time to present, but that is called the dual syndrome hypothesis. We also looked at the effect of mild behavior impairment on cortical thickness, gray matter measure, and we found that when we compare the Parkinson's patients with mild behavior impairment to those without, there was significantly thinner medial and anterior temporal lobe. And we also found it when correlating the MBIC with thickness. The higher the MBIC, the thinner the anterior temporal lobe. So this is in accordance with the other studies showing that thinning of the anterior temporal lobe was associated with significant cognitive decline. We also used, once again, the card sorting task fMRI protocol, comparing the Parkinson's patients with and without MBI as well as healthy controls. And what we find is that there's no significant decrease in the frontal and striatal regions in the Parkinson's patients without the neuropsychological load, whereas there's significant reduction in that activity in the Parkinson's patients with MBI. We also looked at corticostriatal connectivity using resting state fMRI. So that's fMRI while people are doing nothing, and you look at how the activity evolves in the ball using the Bolt signal. And what we were interested in was connectivity between the default mode network and the striatal network, the central executive network and the striatal network, as well as the saliency network and the striatal network. And what we found is that there was significant decrease in connectivity between the default mode network and the striatal network between the Parkinson's patients with the neuropsychiatric lobe compared to those without, and those with the neuropsychiatric load compared to the healthy controls. Similarly, we found a similar result for the connectivity between the saliency network and the striatal network between the Parkinson's patients with mild behavior impairment and those without, and those with mild behavior impairment and the controls. We also did some diffusion imaging, including DTI, where we looked at various groups of patients. So the healthy controls, the Parkinson's patients with mild behavior impairment or mild cognitive impairment, those with mild behavior impairment but not mild cognitive impairment, those with MCI but not MBI, and those with both. So as I said, we do a battery of neuropsychological evaluation, do the MBI checklist. They do MRI, anatomical, or diffusion. And we looked at these various measures. This is what they could correspond to. I'm not going to go over that. And we looked at the connectivity, white matter integrity between the superior, medial, inferior, and orbital gyrus to the hippocampus, amygdala, nucleus accumbens, caudate, and the putamen, and also connection between these subcortical regions. So the results showed that when you compare Parkinson's patients with mild behavior impairment, that's the neuropsychiatric symptoms, to those without, there was a significant problems in the connections between the amygdala and the inferior frontal gyrus, the amygdala and the putamen, as well as the amygdala and the hippocampus, and between the amygdala and the putamen. So these are usually regions that are thought to be limbic regions. So it would make sense that they have a link to neuropsychiatric regions, to neuropsychiatric symptoms. On the other hand, when we look at the Parkinson's patients with mild cognitive impairment compared to those without mild cognitive impairment, with normal cognition, it's much more the connectivity between the caudate nucleus and the various frontal regions, as well as the caudate nucleus and the hippocampus, that are affected. And it is thought that the caudate nucleus is the nucleus in the striatum which has the most relationship to cognitive function. Finally, when we looked at the effect of both MBI and MCI together, we see that it's not so much having MBI on its own or having MCI on its own that affects the white matter connectivity, but it's really the effect of having both in the disease where there's the most white matter connections that are affected. This is what this diagram shows. We also looked at a little genetic effect and how it affects mild behavior impairment in Parkinson's disease. So we looked at what's called the Val66 MET genotype in the brain-derived neurotrophic factor gene. And what we found is that MET carriers had twice as much chance of having mild behavior impairment than individuals in the Val-Val group. And when we compare their scores on the MBI checklist, they were globally more affected. The MET carrier were globally more affected than the Val-Val group. And this was driven by the scores on the mood and anxiety, as well as the abnormal thoughts and perception domains. So as an interim summary, mild behavior impairment could be a practical marker for early detection of cognitive decline in Parkinson's disease. So we have an ongoing longitudinal study to test that. In the future, we'll also evaluate in collaboration with Jean-François Gagnon whether mild behavioral impairment affects the trajectory of progression towards synucleinopathy in RBD patients. So as we mentioned at the beginning of the talk, the presence of idiopathic REM behavioral sleep disorder is predictive of developing within the next 10 years either Parkinson's disease or Parkinson's or Lewy body dementia. And we want to find out whether the presence of mild behavior impairment could affect this trajectory. So I'm going to shift a bit topic, though there's always a relation between pain, cognition, and neuropsychiatry, but we're not there yet. We will eventually study it. I'm going to talk about the prevalence of pain in Parkinson's disease, and particularly the prevalence of chronic pain. So about 40 to 85% of patients experience chronic pain in Parkinson's disease, which is approximately twice as much as in the general population. So painful symptoms often appear at the initial stages of the disease, as we saw, the stages where the motor symptoms starts appearing. They have gradual change as the disease progresses. Importantly, they have a greater impact on the quality of life than motor symptoms, at least at the initial stages. And they're often undiagnosed or misdiagnosed, possibly because the patients focused on their motor dysfunction with the neurologist and so on. So what we want to find out is why is there such a difference in occurrence of chronic pain in Parkinson's disease compared to the general population. And we're investigating different mechanisms. We were wondering if alterations in the sensory profile, so that's such as pain sensitivity. So what's, for instance, the minimal heat temperature I can imply to you on which you feel pain, or the minimal or vice versa with cold temperature. Or could that be altered, or could pain modulation mechanism be at the origin of high prevalence of chronic pain in PD patients? So for instance, if I apply to you a very hot stimuli on one hand that you find very painful, and then I still apply it, but on top of that, I put your other hand in a very cold bath, suddenly your rating of the heat pain will go down. This is one way of pain modulation. We're going to study two, which I'm going to explain afterwards. So what we want to find out is whether these sensory profiles and pain modulation mechanisms are similar in Parkinson's patients with pain to those without pain, and how do they compare with those of chronic pain patients without PD. want to find out whether L-DOPA modified pain profiles in PD, and what are the neural, and eventually using fMRI, what are the neural and functional signatures of nociceptive processes in PD. Differences in activation patterns during painful experience, but also painful expectation will be explored using fMRI. So one of the original part of our studies is that we are studying 4 groups. Parkinson's patients with pain, mostly lower back pain. Parkinson's patients without pain. A group of chronic lower back pain patients, there's such a network in Quebec, who do not have Parkinson's, and a healthy control group. And we want to characterize the sensory profiles, pain thresholds, and so on by comparing Parkinson's patients on and off, but also those 4 groups, and discover the differences in the effectiveness of pain modulation between those 4 groups. So the pain sensitivity are measures using a firm mode like this one, where you can very rapidly change the temperature you apply on the skin of someone. So this is referred to as quantitative sensory testing. This I've already said. So what do we already know about this? There's been some contradictory results, but overall, the literature reports decreased pain threshold and tolerance in PD compared to healthy control. Pain thresholds only on one study have been shown to be lower in Parkinson's patients with pain compared to those without pains, and levodopa seems to improve pain sensitivity. So we're also using a conditioned pain modulation paradigm, so that's what I was describing to you with the heat pain on one side and the cold pain on the other. And there's been a preliminary study in de novo patients who did not have pain that found no significant difference between Parkinson's patients and control. However, there was an effect. The counter-irritation effect seemed to be weaker in PD, meaning that they felt the effect wasn't as good, so they still had a lot of pain in the initial target. So we're trying to find out whether with a bigger group and also using Parkinson's patients who have more advanced and have pain, whether we'll find a significant difference. There's one more modulation effect that can be studied, which could be referred to as a cognitive modulation effect. So if I give you, if I induce a pain that you usually consider moderate, but if I tell you, if I give you a cue before that this is not going to be painful, this is going to produce some hypoalgesia. If I do this, if I do the contrary and I give you a cue that this is going to be very, very painful, it's going to produce hyperalgesia. You're going to rate it as higher as usual. And if I give you a low cue, it's going to rate it as low as usual. And this has been shown, so a priori expectation can have an analgesic effect on pain perception. And it's known to depend on dopaminergic system and also on the opioid system. So one could expect that it might be affected in Parkinson's disease, and that's what we're studying. So we've completed about, we're trying to target 30 patients per group. This is a very heavy, it's a very long study because they have to come multiple times and do all this stuff. So in the future, we're going to compare patterns of neuroactivities in patients with and without PD, with and without chronic pain, during pain expectation and pain perception. This was done in healthy individuals. We'll do something similar in Parkinson's patients. But I'd like to finish the talk about, low-intensity focused ultrasound or transcranial focused ultrasound, which we're hoping to use to modify pain sensitivity in patients with Parkinson's disease. So here, there's an expert in that, in actually using both LIFU and in Parkinson's disease. It's called Robert Chen at the University of Toronto. So low-intensity focused ultrasound uses transducers that contain piezoelectric elements to produce pulses of ultrasound waves that can come together. So one of the advantages is that it can sonificate not only the cortical regions, but also the very deep structures, both non-invasively and with a high level of spatial resolution on the order of a few millimeters in diameter. So LIFU should be distinguished from high-intensity focused ultrasound, HIFU, which is used for neurosurgical ablative interventions in movement disorders and brain tumors. It's used here as well at the Toronto Western to treat tremor, either for essential tremor or for Parkinson's. And we've performed an initial study using this, where, so the idea is first you model the skull to try and model exactly how deep you're gonna sonicate, which results in a type of stimulation, if you wish. And this is what, this is a very precise machine and a heavy one. We also use neuronavigation, and this is the targeting. But we're a bit like at the early stage, the early days of TMS. We don't know what the different parameters of sonification, what are they gonna do with respect to cortical excitability, for instance. So this is what we did in the first study. We looked at the rates of pulse repetition frequency, so the frequency of these pulses. And so unlike TMS, focused ultrasound does not induce MEPs on its own. So you measure cortical excitability based on TMS-invoked MEPs. So this is what the setup looked like. We had a baseline where we looked at resting motor threshold using single pulse stimulation. Then we had 4 randomized conditions, so people had to come back 4 different times using different pulse repetition frequencies, 10 hertz, 100 hertz, 1000 hertz, and there was a sham condition. And then we measured cortical excitability based on the resting motor threshold after 5 minutes after sonification, 30 and 60 minutes. And what we found is that only the 10 hertz and the 100 hertz sonification had a significant effect on cortical excitability, and they were inhibitory. For the 10 hertz, the effect lasted up to 30 minutes, but for the 100 hertz, it was carrying on even after an hour. There was no effect in the sham or in the 1000 hertz condition. So the idea is that in the future, we just received a system like the one you're seeing, which is also focused ultrasound. We want to use such a system in Montreal. This was done in Calgary, sorry, the previous study. We want to use such a system because it has been shown, there's been an initial study that has shown that in healthy individuals, they could modulate the pain sensitivity using this method, sonificating in the ventromedial thalamus. So thank you very much for your attention. I'd like to acknowledge all my collaborators, my students, as well as the funding agencies.
Thank you so much. That was a really very interesting talk. With respect to the studies that you were talking about, looking at MCI and MBI, you talked about them often as kind of binary, with MBI, without MBI, with MCI, without MCI. But these are continuous variables. So I was wondering if, when you look at your quadrants, do you find that, for example, in your quadrant of those individuals who have both MCI and MBI, do they tend to be on the more kind of higher end of the impairment spectrum?
Totally. And it's actually thought that it's the same thing going on outside the context of Parkinson's disease. And so I did talk a little bit about this, but with respect to white matter integrity, not with respect to cognition. But you're completely right. Yes, it's actually the combined effect that's the worst.
Okay. And then just quickly follow up. I know that you can't determine this based on the current data set, but in terms of the causal mechanisms, so it was kind of alluded to maybe that there's the same sort of neurobiological mechanism that may be producing both the Parkinsonian symptoms as well as, for example, the MBI and the MCI. But could it also be the case that it's an indirect association? So is it possible, for example, that people who have sort of worse Parkinsonian symptoms and or more severe MCI, that is what's causing the MBI? So when you have worse symptoms cognitively and physically or motorically, then it's leading to apathy and depression and these other MBIs.
I really think it's the contrary, but we need to test it. You can only test that longitudinally, and ideally with even prodromal patients, and that's kind of where we're doing the RBD patients as well. I don't have a proof either, but I actually think it goes the other way around. One of the reasons is that depression can occur before the motor symptoms in Parkinson's disease.
Other longitudinal evidence that speaks to that.
Yeah.
Okay, thank you.
I have a question. So for pain could be a non-motor symptom, but could also be a motor symptom. It could be modulation in the brain, but it could also be caused by rigidity and muscle tenseness. And especially when it comes to L-DOPA, how do you delineate the two sorts of...
Good question. So I didn't go into the tricky subject, which is important, but I didn't want to go into it, of pain classification in Parkinson's disease. It's extremely complex problem. And what you're referring to are pain symptoms which are linked to the motor symptoms directly. And we are excluding these. But yes, they're very important to study as well. Well, we're trying to exclude these as much as we can, let's be honest, because you can never completely exclude. But the primary pain has to be the lower back pain. Of course, they can have others, but that's what they need.
I guess it's a little bit of a continuation of Jenny's question. I don't really know at all, actually, embarrassingly so, if dopaminergic medications affect cognitive symptoms at all, or deep brain stimulation techniques. Do they somehow improve cognitive presentations?
So it's very complex. At the early stages of the disease, they can do both. We had a study showing that. Depending on which part of the striatum your cognitive task is linked to. Because medication is optimized for the motor symptoms and the putamen. But at the initial stage of the disease, there's more of an imbalance with the ventral striatum because it's not yet affected, but yet you're sending dopaminergic medication. So we've shown that it kind of improves for caudate nucleus-related tasks and for ventral striatum. As the disease evolves, towards the end of the disease, the L-DOPA is actually improving it. Medium stages and the later. But it's kind of an inverted U shape. There's a Cambridge group that has shown this. And it's quite a complex relationship. Right. But overall, it does improve because there's the global attentional effects. They're much more concentrating when they're on than off.
Great, thank you.
I have another question. In your machine learning study, you had two. In the first one, you showed that R squared was 0.1, In the second one, you didn't show, but I imagine it would be the same because you said the new features didn't add much, or were not.
Anyone?
You did not mention the R squared.
Sorry, it was better in the second one than in the first one. But I do not know it by heart. But it was actually quite a bit higher because we had many more features.
So I have two questions.
But it wasn't necessarily, I wouldn't claim that it was particularly high. The point was more to rank the features than to achieve the best.
So I have two questions about that. One is, was L-DOPA dosage one of the features? Because you had...
we probably had lead.
You had it?
Yeah.
Okay. So then, like, if it's 10% or 30% or whatever, so what else could it be? Because you had brain imaging, you had motor symptoms, you had genotypes.
And CSF.
And CSF.
Yeah.
And that all of that combined explains 10% of the variance, or even if it's 3 times more, 30. What else could it be? You have everything.
No, I agree. But what's interesting is that it didn't pick up the imaging. It didn't pick up the genetic.
Yeah, I mean, what is it? What is the rest of the variance coming from? Where is it coming from?
Oh, good question. Yeah, no, I understand what you're saying. Yeah. One of the big issue with studying this is the heterogeneity of the patients. They're extremely heterogeneous, and yeah, I'm not too sure actually.
Any other questions? Okay, it's a little bit past 1, so we can thank our speaker one more time. Keeping note, if you haven't signed up on the sheet, please do on the way out, because that's just to keep track of how many people usually attend and how much pizza we need to order and things like that.